We will now move on to our second Q&A session. So once again, please use the Q&A button below to post your questions for the panel.
Okay, thank you, Ying, and thank you all presenters. One thing you would have noticed, most of our presenters are early career researchers. And one of the key things we have achieved in this very short time of 6 months is to bring together researchers across the 4 nations as one family who are able to access each other's database and conduct research that are extremely meaningful and take us forward in our journey over the next 3 years to solve so many challenges. So while we wait for questions from the public, may I start by asking a few questions to our panel members? One of the things Mary pointed out is very limited knowledge in terms of how do we manage, and quite often most of the ability to manage that is put back onto the patient. So, and this is a reflection maybe of limited knowledge on the outcomes. What will be the health outcomes of women living with 2 or more health conditions? And how does knowing these outcomes can have an impact on how we care for these women? Can I ask that question to Professor Catherine Nelson-Piercy, please?
Thank you, Krish. I think that's actually a really hard one. I think if we were all coming back to what Mary said, but what struck me most is the fact that currently it's left up to empowered women to fight their own corner. And I have every faith in our PPI group that although they are all empowered, they actually do take very seriously the fact that they are representing more disempowered women. So I want to reassure the audience that although they are all white, educated, eloquent women, they are very, very aware that their reach is much wider than that through, as Nawe was saying, their connection. So that's the first thing I want to say. Women worry, we know through the PPI group that women worry about the effects of their medication on their baby. Every single woman who's ever been pregnant, even myself, I didn't want to take a decongestant because I thought it was going to give the baby 2 heads. You know, every woman starts her position like that. And we as healthcare professionals have to understand that overwhelming fear that women have. So the core outcome set and the data will hopefully partly reassure us that even women taking multiple medications, and particularly certain typical clusters of medication, that hopefully their pregnancy outcomes will be normal or will reveal any issues. So the importance of the core outcome set is to agree what's important to women and to their healthcare professionals, and secondly, to look for what we would call signals for anything. For example, what an important outcome in obstetrics is preterm delivery. So any signal that a drug combination or a combination of mental or physical health conditions predisposes to preterm labor is really, really important in terms of that mother's health and her baby's health. So I'm slightly waffling again, Krish, because I've actually forgotten what you asked me.
Well, I think you have partly answered, but why is it important to know what are the health outcomes? So I think you went into 2 key issues. One, we really don't know if most medications are safe or not when prescribed in combination. And one thing it will do is, of course, give that reassurance most are safe, but it will also tell us which medication may not be safe and we need to take caution. And that will be a huge, huge impact in terms of knowing what we are facing. And the same when it comes to combinations of health conditions. So, so thank you for that, Catherine.
I just want to add again, Catherine Abel may wish to comment, but There are so many papers out there about the potential risks of SSRI on the fetus. And we, as a consortium and a group working together, are very well aware that we have to balance the benefit of drug therapy for mental and physical health versus any adverse effect. And how we, again, that's where the core outcomes are really important. You might have to take, and anti-epileptic drugs are a really good example. Some anti-epileptic drugs can harm the fetus, and everybody knows that. But poorly controlled epilepsy is potentially far more dangerous for the mother than the risk of the medication is to the fetus. And you can extrapolate that argument for inflammatory conditions, mental health conditions, and it's using the evidence to best inform practice and best inform counselling. And as I said before, knowledge is power. And so we're trying to get more knowledge.
Thank you. Catherine Abel, do you want to say a few words around one of the key things, Catherine? I think one of our discussions you mentioned, when we talk about impact, what does it mean to us as opposed to those women and the public, and how do we align it? So if you can talk us through how best to align the impact we have through this research.
I don't know how best to impact, but what I do know is that we don't know that. And I also know that we can't rely on one person's testimony and that it's going to be appropriate for everybody's experience. And we're all very well aware, I think, today that we don't have representation from some of the highest risk groups and some of those who remain underserved by research. And we particularly know in mental health that the population of people with mental illnesses relative to other physical conditions is woefully underserved in its representation research, and that we are, you know, as guilty as everyone else for underrepresenting rather their views today. And so I think that's terribly important for us to bear in mind. What I really think is important in relation to the complexity of these questions, and if I, for example, use Catherine's question about neurodevelopmental disorders, the effects of SSRI taking in pregnancy on fetal and child outcomes. So there's been some extremely high quality work and some very poor quality work. So if we just focus on some of the higher quality work from Sweden and the large population data sets that shows there is an increased risk for autism spectrum disorder from some SSRI during pregnancy. The problem, and this is where we have to be absolutely clear that the dissemination and the impact is really linked and aligned with what the needs of that woman that Mary may have described, being in the clinic with the doctor, giving them all this information, and yet at the end of the day being told, you've got to make this decision, this is your decision, and feeling really anxious and overwhelmed by all of that complexity. And I think what we need to do is fess up, if you like, and say there are different roles of the doctor for different people, different roles of the multidisciplinary team for different people. Some people simply want to be, if you like, guided through information, but really to come to their own decisions. And that's absolutely appropriate that we should do that. Others really don't want that, and they really want you just to say, please, can you make this decision for me? I don't feel able to do that. And I think there's room to have very different approaches to information provision and to the meaning of that information and to the meaning of outcomes for individuals. And of course, we've discussed as Krish some clever things that could be done in the next phase of the study to try to inform that process and make it a much clearer process of what can and can't be done in that kind of realm of complexity.
Thank you, Catherine. We will have to move on now, but before that, one of the things we are doing is we have observed is what happens in pregnancy tells a story in itself. So women who do not have multiple health conditions go into pregnancy, have specific complications like miscarriage, like gestational diabetes, like preterm birth, information that helps us to understand their health course over the next 5 to 10 years. And one of the things we wanted to do is to build predictive algorithms to understand after pregnancy, how women accumulate health conditions, and that in turn helping us to detect disease early. Professor Colin McEwan, how do these predictive algorithms impact in terms of improving care for women after pregnancy?
Thanks, Chris. So earlier on, Mary had mentioned about the difficulties she had during her pregnancy, and Catherine suggested one of the solutions to that was having a single point of contact, so you didn't need to keep relaying your story. The other thing that we really need to think about as well, though, is people need experience of how to deal with different people with different conditions. So what we all want is a clinician who's listening to our story, who's got experience of dealing with these type of problems we're explaining to them, and then knowing what to do next. And that's what we're hoping to do with these predictive algorithms, and what we're hoping to do with these databases we're setting up. By looking at the data across the UK, we can identify lots of people who may be unique when they go to their individual doctor or their individual obstetrician, but there's lots of them across the UK. And what we're hoping to do is, with our predictive algorithms, we're saying, okay, well, we think the best course of action for these people are whatever that pathway would be. And it allows us to start then thinking about, okay, well, what do we need to be aware of? What should we be looking out for? What sort of preventative care can we put in place to ensure that this individual woman sitting in front of me as a clinician, or her child, have the best possible outcomes? And that's what we're looking to do with the whole project. It's about trying to pool shared experiences, shared knowledge, and making sure that we can provide individual care as best we possibly can.
Thank you, Colin. So what you are saying is you're not alone. Across the UK, there are many, and we can use that information to shape care by understanding what works best for them. Excellent. So with that in mind, Ing, if there is no other questions to answer, I did see a couple of questions, and I think, Ing, you are going to separately answer to them.